Good morning to all of you all, and we are going to talk about pathogenesis of TB and MDR TB. Here we are going to explicitly talk only of MDR TB. Now, before we talk of pathogenesis, you should understand how you get TB. What happens in the body is later, but first is how do you get TB. So, it is airborne. You don't get it through contact. It is airborne. It's there, it's suspended in your atmosphere as droplet nuclei. And that droplet nuclei are pretty large particles. They can remain suspended in the air for quite a few hours. So even when you are in your clinic and you have a patient who comes to you with TB, try and open out the windows as far as possible. Even if you're sitting in an AC room or an AC cabin, get that ventilation in place. So if you have the ventilation in place, these droplet nuclei will disperse out. Okay, so it's going to remain suspended. Now when these droplet nuclei, how is it, any patient who has open TB means fibrocapillary TB, smear positive TB, miliary TB. So anyone who has this kind of TB, when they cough, they sneeze, they sing, then you're going to get these droplet nuclei in the air, and then they are going to remain suspended till somebody ingests it or it gets destroyed by the UV light of the sun. So you are going to get it usually inhalation. I'm going to talk about pathogenesis related to inhalation. Then we'll discuss about how do you get abdominal TB. Now, the more number of bacilli that a patient has, so 3+ AFB smear positive, 2+ multibacillary disease, they are going to be more infectious. Children are going to be paucibacillary disease. So children are going to be less infectious to you. But don't think that just because you're seeing children, that means you're not going to get TB. As residents, you all have to be very careful about TB. Somehow in residency, I have seen almost 10% of residents getting tuberculosis. And it's really related to taking precautions. If you take proper precautions, you will not land up with TB. But you all have to be very careful. Try and wear a mask whenever you see a patient with tuberculosis. Don't assume that because he is paucibacillary, his parents are not infected and they could be multibacillary. So be careful about that. Open up the spaces. Ideally, you should have air changes almost 12 cycles an hour. So if you have 12 cycles an hour air changes, then these bacilli will get dispersed faster. Or you should have UV light in your room, or you should have a HEPA filter which disperses out which sterilizes the air. So these are the things that are required. If you don't have this and you have a plain simple AC in your room, open out the windows. Now what happens when these bacilli reach the lung? So these droplet nuclei you inhaled, they finally go into the lung. In the lung, they remain in the alveoli. From the alveoli, they are ingested by the alveolar macrophages. Now the macrophages, they are present in the phagosome. So most of the bacilli are going to be destroyed in the phagosome. Sometimes these phagosomes are not able to destroy the bacteria. And then they would be again spreading out. These macrophages would die, these bacteria would come out, and then they would spread either hematogenously or lymphatically. So if it spreads, it can spread to other parts of the lung, it can spread through bloodstream, into the bones, into the brain, into kidneys. So that's how the bacilli spreads. But if the macrophages are able to contain the infection, then what you get is only latent TB. So host immunity is also very, very important in maintaining immunity against TB. Now these infected macrophages, if macrophages were the only ones that were destroying the bacilli, why would we get a positive MAN2? MAN2 is a delayed hypersensitivity reaction that is produced by the WBCs, the lymphocytes. So what happens is when these macrophages are there in the lung, they release certain cytokines. I'm not going to go into all those pictures of various cytokines, the toll receptors, the tumor necrosis factor alpha and all that. But these chemokines, they attract the WBCs towards the site of infection. None of these WBCs can kill the bacteria very efficiently. So what happens is they try to wall off the infection by forming granuloma. So these macrophages with the lymphocytes form giant cells. They formed epithelioid cells around it and they try to wall it off. Now, once these macrophages are killed with these bacilli, it leads to formation of caseous material. So you have this caseous material walled off by the granuloma, and surrounded by the inflammatory cells that are your lymphocytes and the monocytes. So that's what your granuloma consists of. What happens is you have walled off the infection, but some of these mycobacteria can remain dormant in these granulomas, and when the immunity goes down, or there is hypoxia, or there is some sort of toxic fatty acids, these dormant bacteria will become alive after a few decades. So that's what you call as reactivation. And that's what you see in adults. They have fibrocavitatory TB, which comes as reactivation. Now, if the granuloma calcifies or it heals, then the infection does not progress to further stage. But if the granuloma, if that WBCs, lymphocytes, macrophages are not able to control the infection, then the TB will progress through the lymph node into the lymph node. So you get a bones focus, primary complex. It can spread from the alveoli further into the alveoli through bloodstream, primary progressive, other lung, miliary TB, into the pleura, pleural effusion. Okay, so once that granuloma is enclosed off and no further disease takes place, it's called as latent TB. If it progresses, it's known as disease. So there's a difference between latent TB and there's a difference between disease. Latent TB, you have the MTB, Mycobacterium tuberculosis, in the body, but it's not causing a problem. Whereas disease means Mycobacterium tuberculosis is causing a problem in your body. So there's a difference between the two. Why it's important to know? Because the treatment is different. Now, how have people defined latent TB? Mycobacterium tuberculosis in the body do not have the disease and cannot spread infection to others. That is a definition of latent TB. And this is what I told you, it forms a granuloma, but it does not spread. So there is a granuloma. If you do a histology, if you cut the lung at that time, you will get a histology which shows a granuloma. And these granulomas either heal by calcification or by small fibrosis. How do you detect latent TB? By a positive MANTU or an IGRA, interferon gamma release assay. So you have suppose done as a screening process, somebody had TB in the family, you screened all the family members and you found somebody had a positive MANTU. You confirmed it by doing a quantiferon and found a positive quantiferon gold. This patient does not have any symptoms or signs of the disease, then you label the patient as latent TB. Why is it important to identify latent TB? We said latent TB is not found a disease. Why should we identify these patients? Because what are the chances that this patient will develop a disease is important. Whenever a person is detected as latent TB, 5% of them will develop the disease in the next 2 years. That's the reason of identifying latent TB aggressively. In fact, if you go abroad, suppose you go to US is a low endemic area for tuberculosis. So what they will do at the time when you immigrate to US is they'll do a MANTU test in you. And if you're MANTU positive, they'll label you as latent TB and start you an INH prophylaxis. If you're MANTU negative, they'll repeat the MANTU after 3 months to see whether you seroconvert. If you converted again, that means you have been exposed to TB recently and they'll put you on prophylaxis. Because your chances that you will develop a disease is highest in the next 2 years. Latent TB in children less than 5 years have a very high chance of developing a disease. So when we are doing contact screening, we actually do MANTU in children less than 5 years and we do an X-ray test in children more than 5 years. Less than 5 years because the chances of developing a disease is very high. After 2 years of age, after 2 years after your MANTU is positive, your chances that you will ever develop TB because of that particular infection is 5% in the lifetime. Okay, so your chances regress over a period of time. So first 2 years are the most critical. So if you have a child whom you are following up because of positive MANTU, be careful for the first 2 years. Maximum infection to disease transfer rate is going to be in the first 6 months. So even when we are actually stopping treatment in patients with TB, we follow them up for the next 6 months because the chance of relapse is highest in the first 6 months. Just as chances of transferring over to disease is highest in the first 6 months. So who are the people at risk of developing the disease? Patients with HIV. 50% of patients with HIV with latent TB will develop disease as compared to normal population where it's 5%. Children younger than 5 years of age, very high chances of going into disease. patients who have been infected with MTB in the last 2 years, that is your latent TB, persons who are getting steroids or chemotherapy agents, patients who have decreased immunity like diabetes, chronic renal failure, leukemia, and in adults somebody who's undergone a gastrectomy or a jejunal bypass, because that's where your gastric acid is less, and that's one of your defense mechanisms against tuberculosis. Now when we talk about pathogenesis, we very well said alveoli, alveolar macrophages, lymphocytes. How long does this process take place? Does it take place in a matter of few days? Does it take place in a matter of weeks? Or does it take place in a matter of months? If we take the stages of TB progression, it's going to be in a matter of weeks to months. And it's divided into 4 stages. Stage 1 is going to last for 3 to 8 weeks. This is the time when you inhale the bacilli in the alveoli. They are disseminated to the lymphatic circulation to the regional lymph nodes, forming the so-called primary complex. And this is the time when you get a MANTO positive. So your macrophages have invited the lymphocytes, and that has caused a positive MANTO. So this stage up to a latent infection or a primary complex will take 3 to 8 weeks after you've been exposed to the bacilli. So suppose somebody had TB in the family, chances that you will develop primary complex is going to be there in the next 3 to 8 weeks. The second stage is 3 months, going to last for 3 months. If the disease is not controlled, it will spread through the bloodstream to other organs such as brain, and the dissemination causing miliary dissemination. So if you have a manifestation of TB and miliary, probably this child was exposed to the bacilli in the last 3 to 6 months. Okay? The exposure is not going to be 2 years back, it's going to be in the last 3 to 6 months. The third stage, that is 3 months to 7 months, is pleural effusion. Now how does pleural effusion occur? It's either due to a hematogenous spread of the bacteria into the pleural space from the subpleural component of the bacteria. The free bacteria are thought to interact with the CD4 cells and release inflammatory cytokines. So earlier what we thought is that pleural effusion is just an inflammatory reaction and you are not going to grow the bacilli in pleural effusion is wrong. You can still grow bacilli in the pleural effusion, but they are paucibacillary. So the disease is paucibacillary pleural effusion. The disease manifestation of so much amount of fluid in the pleural space is inflammatory. Okay? So these bacteria release the CD4 cells release lot of chemokines, and that causes the fluid accumulation. Same mechanism for ascites. You have bacteria in the intestine or the lymph node. They go into the peritoneum, cause an inflammatory reaction. The peritoneum is going to release lot of cytokines. If the fluid is too much, it will form ascites. If the fluid is less, it's going to form fibrous vein, and it's going to cause a plastic fibrinous peritonitis. Same mechanism for pericardial effusion. Okay? So pleural effusion exposure is going to be somewhere from 3 months to 7 months. Fourth stage, slow growing bacteria. The lung lesion resolved, body took care of it, but by that time the bloodstream infection started growing, and they're growing slowly. So growing slowly in areas like bone or the kidneys. So if you have a bone TB coming to you, or you have a renal TB coming to you, probably the exposure took place 2 years or 3 years back. Okay? So from the disease manifestation, you could actually estimate how long was the exposure, how many years back was the exposure. Among the pathogenesis, we talked about how the Ghon's focus occurs, how it spreads through the lymph nodes and through the bloodstream and spreads into various parts of the body. But we didn't discuss about abdominal TB. How does abdominal TB occur? Does it occur because of inhalation? Now we all know that abdominal TB occurs either due to MTB or M. bovis. M. bovis comes through unpasteurized milk. Nowadays most of the milk is sterilized, so you hardly get M. bovis infection coming. So most of the time your route of infection is still through the lung because of swallowed sputum, or it's a lymphohematogenous spread. Rarely it's going to be an infected milk that you are ingesting and your primary is going to form in the intestine. It's usually the primary is still in the lung and you have swallowed the sputum, or you've got a hematogenous spread. Now the areas involved in the intestine, any part of the intestine get involved, but they have an affection for the ileocecal junction. Why is the ileocecal junction very important for TB? Because that's the area rich in lymphoid follicles. So that's the reason your ileocecal junction is really involved, but you could get jejunum, you could get ileum, you could get any part of the intestine being involved. So now this was about pathogenesis of TB. I hope all of you all are clear about pathogenesis, how this particular bacillus you inhale, how do you get it, mode of transmission, and what it does in your body. So now we come to drug-resistant TB. A lot of changes in drug-resistant TB. This is the 2014 update that I'm giving you. We are still in the year 2014. So this is the latest update of drug-resistant TB. Now when we talk about drug-resistant TB, you first need to know your definitions. So you need to know what is monoresistance, polyresistance, MDR, XDR, pre-XDR, XXDR, and now a new terminology that is known as RR, rifampicin resistance. So when you have a drug, only single drug that is resistance, you call it as monoresistance. If you by chance detected single rifampicin resistance, which usually does not occur, you call it as rifampicin resistance. Rifampicin resistance, what is this terminology RR? Means they have detected resistance to rifampicin. Either the lab only tested for rifampicin by doing the regular DST, or they did a molecular test like Xpert, which only looks for rifampicin resistance. So it does not mean that the patient is not resistant to other drugs. Okay? If you have rifampicin resistance, it is always assumed that INH is resistant along with it. Isolated rifampicin resistance does not occur. So when you have this rifampicin resistance detected by a lab which has only tested for rifampicin and not tested for other drugs, you call it as rifampicin resistant. So it could still be monoresistant, it could still be polyresistant, it could still be MDR, XDR. Okay, it does not tell you isolated rifampicin resistance. Polyresistance is resistance to more than one drug, and you don't have to have INH and rifampicin together. If you have INH and rifampicin resistance together, it is known as MDR, multi-drug resistance. It's not called as polyresistance. Why this difference? Because your INH and rifampicin form the backbone of TB regimen. It's the backbone of your intensive phase, it's the backbone of your continuation phase. So if you're losing both your backbone, INH and rifampicin, it is a time to worry, and it's called as multi-drug resistant and not polyresistant. When you have polyresistant, the combination could be INH streptomycin or rifampicin ethambutol. Okay, it's never going to be INH and rifampicin together. Why is it important to know the difference between the two? Because treatment is going to be different. Polyresistant treatment may be 9 months, maximum 1 year. You may not use injectable agents. Whereas MDR TB, treatment is going to be 18 months, 20 months nowadays, 20 months therapy, and you are going to use injectable drugs for a pretty long time. So the therapy completely changes. Now we have a term called as an XDR TB. XDR is extensively drug resistance, means you already have an MDR, INH rifampicin resistance, plus you are resistant to one of the fluoroquinolones, and you are resistant to one of the injectables, of which you don't count streptomycin, you count amikacin, capreomycin or kanamycin. Okay, so XDR means MDR, INH rifampicin, fluoroquinolone one of them, and injectable one of them. This is known as XDR TB. And then you have an XDR TB, which I'll come to later, and you have a pre-XDR. Pre-XDR means you have an MDR, that is INH rifampicin, plus either a fluoroquinolone resistance or an aminoglycoside resistance, not both of them. So that is known as a pre-XDR. We initially used to label these patients as partial XDR, and now WHO has come with a term known as pre-XDR for these patients. Okay, so there is a terminology known as pre-XDR, which I have not included in this slide. Then came a terminology in form of TDR. All of you all have heard of the term TDR? Totally drug resistant TB. This really created a havoc in the city of Mumbai, or probably in India, when few researchers reported TDR. Now this was actually first reported in Iran in this paper which was there in chest, which was super extensively drug resistant TB or totally drug resistant TB. So the first terminology of TDR was given in Iran. Subsequently, this paper from Hinduja Hospital which was published in Clinical Infectious Disease. And they reported 4 patients resistant to all the first line INH, rifampicin, ethambutol, pyrazinamide, streptomycin. And second line, your Oflox, Moxiflox, the quinolones, kanamycin, amikacin, capreomycin, the aminoglycosides, PAS, ethionamide. So these are the DSTs that were done. They have not tested for cycloserine, clofazimine, linezolid. All those drugs have not been done. But they tested for all the possible DSTs that are available and all of them resistant to everything. So they label these patients as TDR, totally drug resistant TB. And you all know it created a big havoc in the city of Mumbai. The central TB team came down from Delhi, the WHO came down, and they all published a lot of literature in newspapers and all that. And this is the 2012 January paper of Times of India, which says central team says it's not TDR, it's XDR, extremely extensive drug resistant TB. Okay. WHO had to come out with a rapid statement in 2012, and it had to say that it does not recognize the term TDR. So now we don't utter the word TDR, we say it's XDR. Now how does this resistance in TB occur? It's either primary resistance or it's secondary. Primary resistance is in persons who are infected with resistant organisms, whereas secondary resistance are acquired occurs during therapy, either because you gave insufficient treatment or you gave wrong doses or patients were not compliant or malabsorption of the drugs took place or there are a lot of drug-drug interactions that were not identified. So patient to begin with was not resistant, became resistant on therapy. That's secondary resistance or acquired resistance. Most of the adults get secondary resistance and most of them get it because of poor compliance. Children usually have primary resistance. They are usually infected with a resistant bug, either from an adult or because of de novo mutation that has taken place in the environment. Mycobacterium tuberculosis always has a de novo resistance also that can occur through exposure in environment, but that is very, very rare. Most of the resistance has occurred because of use of our antimicrobials, which are left, right, center haphazardly. Now, what are the risk factors of getting infected by a drug-resistant bacteria? That is primary resistance. What is your risk factor? Either you are exposed to a person who has a known drug-resistant TB, or the child is exposed to a person who has TB but is not taking the treatment properly, or a patient, exposure to a patient who is having TB and has still not become smear negative even after 2 months of therapy, or a patient who is traveling to an area which is very highly endemic for MDR TB, or a patient who is on treatment with TB and we don't know the DST reports, the drug susceptibility reports. So when you have these kind of risk factors, you have a high chance of getting infected by an MDR strain. How do you diagnose? Presentation of all these patients is going to be similar. There is no difference that because a patient has drug-resistant TB, there are going to be different symptoms. Symptoms are still going to be same. It's still going to be fever of more than 2 weeks duration, cough more than 2 weeks duration, loss of weight, loss of appetite. There's not going to be any change in the symptomatology of the patients. But if you know these risk factors, you will have a strong suspicion when you should suspect MDR TB. And how do you diagnose MDR TB? You diagnose on the basis of either phenotypic drug assays, that means you grow the bacillus on a culture. From the culture, the grown bacilli is inoculated into the disc with the drug and you look for zone of inhibition. So you look for zone of inhibition of growth in the presence of, that's the standard way that we do phenotypic drug susceptibility test. Now this particular test, the phenotypic assay, requires growth of the bacilli. So you need to grow the bacilli in a culture. You have 2 culture mediums, you have a solid media, you have a liquid medium. The solid media is the LJ medium. It takes 6 weeks for the bacilli to grow. You have the liquid media. Liquid media is your Bactec or your MGIT. It takes minimum 2 to 3 weeks for the bacteria to grow. So by the time you actually do DST on a culture, it takes time. You would lose around 3 to 6 weeks just for the bacteria to grow. Plus the phenotypic DST takes almost 2 weeks. So after you've grown bacilli on the culture, another 2 weeks before you get a phenotypic assay. The advantage is you get the MIC levels. So you exactly know which drug to use. Sometimes you have an MIC of INH. So if you have an MIC of INH, very low MIC, you know you could still give higher doses of INH and treat the patient. If you have a very high MIC, you know you cannot give a high dose of INH to these patients. So it helps you in that way. Plus, DST phenotypic, you could test 13 drugs as compared to genotypic assay, where you can test for probably INH rifampicin. And now with the line probe assays, you could test for fluoroquinolones, ethionamide, ethambutol, pyrazinamide. But the phenotypic assay definitely gives you an advantage that you can test for all possible drugs that are available. The genotypic DST is based on molecular test. It's based on NATS, nuclear acid amplification test. It will look at the PCR, detect the bacilli, look for a particular mutation. So if you have an INH resistance that you are looking for, you look for INHA gene mutation, or you look for the CAT mutation. If you have a rifampicin that you're looking for, you look for the RPO mutation. So you are looking at specific mutations. The turnaround time for genotypic assay, if you're doing Xpert, 3 hours. If you're doing LPA, probably 48 hours. So the turnaround time is very fast. The thing is, you don't pick up additional resistance. So you're not only wiser by doing only Xpert or only LPA, you will still have to do a DST, especially in areas where there are other drugs that are getting resistance. So let's talk about Xpert. Now it's a fully automatic, it's a cartridge. So you put the sputum or you put the body fluid, whichever you've taken, put it into the cartridge, put that cartridge into the machine, and the machine gives you a reading after 2 to 3 hours. It will only test for rifampicin resistance. It will first look whether there is TB or not TB, and then it will look for rifampicin resistance. Now the latest guideline WHO says that you should use Xpert as initial diagnostic test. As initial diagnostic test rather than microscopy, culture or DST. Why? Because one, you get a result in 2 hours. So you would be able to start a MDR treatment regimen much earlier. That's good. But the only disadvantage is the statement rather than microscopy. I mean, you wouldn't be able to say that you don't do microscopy. How will you know the other drug sensitivity? So you will have to do a Xpert along with the other test when you are looking for TB and especially MDR. So when you go through WHO recommendations and you go through on what basis have they made this statement, this is a rapid advice that they've given based, extrapolated from adult studies. Children data is very, very rare, and Indian data is not there at all regarding Xpert. So if you look at WHO recommendations based on Xpert, they've taken 16 studies, 12 published and 4 unpublished. The sensitivity as compared to culture for diagnosis of TB was 66%. So your culture would still pick up more as compared to Xpert for diagnosis, where you use sputum. And the sensitivity was 66% where you took gastric lavage. Specificity was very high. So if you got a bacillus, definitely it was TB. It's not false positive. In culture negative specimens, sensitivity was only 4%. How was that based? So if you have a culture negative and the culture didn't pick up TB, your Xpert picked up only 4% of the patients, but you still made a diagnosis of TB based on clinical situation. Mantoux positive, Cox contact, how we do clinical diagnosis of TB. So in that, the sensitivity of Xpert was only 4%. From gastric lavage was 15%. Sensitivity of Xpert to detect rifampicin resistance is 86%. So WHO made a statement that you have to use Xpert rather than cultures as the first line test for diagnosis of TB. In suspected MDR, there was one. In all patients, that's the second recommendation. So if you're going to do it in all patients, you will have to be careful how you interpret. You will still be missing out quite a few TB if you only take Xpert for diagnosis. You would still need to go on to clinical diagnosis of TB. Now there's a Cochrane review published which has been done on adults, and they thought that Xpert is quite sensitive and specific compared to smear. Smear can be paucibacillary, you could still get it negative. It increases the rate of TB detection. It has a higher sensitivity for TB detection in smear positive and smear negative. If you ask the labs, They'll tell me, please don't do gene expert till you have 2+ AFP on the smear, because otherwise gene expert will be negative. That's what the labs tell me. Which is what we see even in the data, that if you have smear negative, chances of gene expert being positive is only 4%. It's not higher than that. For rifampicin resistant gene expert, very accurate results, and you could immediately change to MDR treatment regimen. So probably gene expert would be very useful in patients whom you're doing where you're suspecting MDR TB, because you get a diagnosis much earlier. Subsequently, there was this meta-analysis which was published in 2013, which says that sensitivity and specificity for smear negative pulmonary TB is only 67%, and specificity is 98%. So obviously false positives are very low, but sensitivity is very poor, 67. So you'll get a lot of false negative. And in HIV endemic areas, the sensitivity even fell further down to 54%. So gene expert is not the gold standard for detection of TB. Probably yes, for detection of rifampicin resistance. Then you have these other molecular tests that are the line probe assays. Now these line probe assays use the same principle. They use a PCR and they use rapid detection of mutations associated with rifampicin and INH. So you have two types of line probe assay that are available. The INO-LIPA, that is only looking at rifampicin, the RPO gene, and the genotype MTB-DR+, that is by Hain, which looks at RPO-B, that is for rifampicin, CAT-G for INH, and INH-A for again INH. To detect other drugs that are resistant, there is a new test by the same Hain Life Sciences that is known as MTB-DRS. It looks also at second-line drugs like ethambutol, fluoroquinolones, capreomycin, amikacin, kanamycin, and viomycin. So at least your XDR TB it can pick up fast, the line probe assays. Line probe assay, again, sensitivity becomes very less if you have a smear negative. So if you have a smear negative and you ask for a line probe assay, probably you are not going to get any result. But if you have a smear positive, 2+ AFP on the smear, and you ask for a line probe assay, you could pick up all the MDR TBs plus the fluoroquinolones and the aminoglycosides very soon as compared to the conventional DST. When we come to conventional DST, it is based on growth of MTB on culture. The first line DST for the first line drugs, most reliable for rifampicin, ethambutol, INH, very less reliable for streptomycin, ethambutol, pyrazinamide. So if your lab tells you it's still resistant, you don't know whether it's resistant or sensitive. The second line DST, again good reliability for injectables and fluoroquinolones. For other second line agents like PAS, ethionamide, we don't know the reliability and the reproducibility. So whenever you ask for DSTs, gene expert, line probe assays, please make sure that you ask it from a reliable lab which is RNTCP approved, NABL accredited, and WHO recommended. Okay, that's the definition of a lab that you should be sending the sample to. Again, cross resistance. Suppose you only did ofloxacin resistance. You didn't check for levoflox, moxiflox. You only did amikacin resistance. You didn't check for capreomycin or kanamycin. Then what happens to cross resistance? All rifampicins are cross resistant. So if you have rifampicin, rifamycin, rifabutin, rifapentin, everything is resistant. INH and ethionamide have cross resistance, especially if you have the INH-A gene. So if you have the INH-A gene mutation, you can assume that ethionamide is not going to work. Amikacin, kanamycin have cross resistant. Streptomycin, not cross resistant. So if you have streptomycin resistance, you could still get away using amikacin, kanamycin. But if you have amikacin resistance, you won't be able to use kanamycin. Probably you could still get away using capreomycin. Quinolones, you have generations of quinolones. Ciproflox, first generation. Oflox, second generation. Levoflox, third generation. Moxiflox, Catiflox, fourth generation. First generation resistance, you could still use second generation. Second generation resistance, you could still use third generation. So if you have Oflox resistance, you could still use Levoflox. Levoflox resistance, you could still use Moxiflox. Earlier we used to use Gatiflox, but Gatiflox is now no longer available in India because of high chance of development of diabetes. So it's been discarded, this molecule, so Gatiflox is not available in India. So again, when we are using combinations of therapy, you need to assume what drug is going to be resistant and accordingly use it. I'll give you an example. This was our experience. We compared our data. We started the TB clinic in the year 2007. So we compared our data from 2007 to 2010, one group, and we took another 3 years, 2010 to 2013, the second group. We looked at drug-resistant TB prevalence in our patient population, and we found in the first 3 years we had 23 patients who were resistant. Transmission rate was around 5.6% prevalence. In the second 3 years, we found 63 patients were resistant, but the number of patients were much higher, more referrals in the last 3 years. So obviously, if you take the prevalence rate, it was 7%. So not much difference in the number of prevalence. What we saw is we started seeing more mono-resistance. That doesn't tell you that MDR is going down. It just tells you that we didn't have mono-resistance being referred to us earlier. Poly-resistance started coming in. MDR, though the number of patients with MDR went up from 15 to 24, the percentage actually went down. And why did this occur? Because the percentage of XDR and pre-XDR went up. So what happened is these MDR who are only isolated INH rifampicin resistance, now in addition started getting fluoroquinolone resistant, in addition started getting aminoglycoside resistance. And that's what you're seeing, the XDR and the pre-XDR went up. And if you see individual drug-wise resistance pattern, in the initial 3 years, INH 100% remained the same, 96%. Rifampicin 95, 80%. So if you have rifampicin resistance, you have to assume INH is resistant. That's MDR. Pyrazinamide remained the same, ethambutol remained the same, streptomycin remained the same. PAS also remained the same. What became resistant is now ethionamide. Went up from 26% to 49%. So we started seeing a changing resistance pattern. We also started seeing a lot of resistance now coming to moxifloxacin, 4th generation quinolone. So what we were seeing is additional resistance to fluoroquinolones coming up. So our MDR treatment regimen had to change now. We could not have a standardized regimen which is being followed in a lot of government hospitals where any child detected with MDR is put on pyrazinamide, ethambutol, injectable, ofloxacin, ethionamide. Now if you look at this, pyrazinamide, ethambutol, we see the resistance is almost 65 to 60% of MDR strains. Not going to work. So if you have a regimen that contains pyrazinamide, ethambutol, not working. Injectable, probably working. Quinolones, not working. Ethionamide, not working. So in the government hospitals, the regimen that they would be on, they would be effectively be on only one working drug. So most of these patients would be failing the regimen. So you must have a conventional DST against all the 13 drugs. You cannot get away with only doing rifampicin resistance if you really want to give a regimen that covers all the susceptible drugs. Okay, so that's why the WHO guideline which says rather than conventional microscopy or DST, I would say in addition to conventional. So Xpert in addition to conventional microscopy and not rather than. Okay, so please take that with you. We don't have Indian data. Indian data should be coming out pretty soon. But till then, it should be in addition to conventional microscopy and DST, Xpert. Now, when we talk about treatment of MDR TB, you need to know various classes of drugs. Always, why are they classified this way? Based on ability to control the disease. The group 1 are the bactericidal drugs, first line agents, INH, rifampicin, pyrazinamide, ethambutol. Group 2 are your injectable drugs. Streptomycin now comes in group 2. Initially it was classified in group 1. It's now part of group 2. Streptomycin is not recommended as a group 1 agent now, not as a first line. So you have streptomycin, amikacin, kanamycin and capreomycin. Group 3 are your fluoroquinolones. Again, ofloxacin has been removed from group 3. Earlier ofloxacin was used. Now with increase in incidence of ofloxacin to resistance, ofloxacin is not used, and now we start with levoflox, moxiflox, gatifloxacin though recommended in WHO, not available in India. Group 4 are your bacteriostatic drugs. Group 4 bacteriostatic are either ethionamide, prothionamide, cycloserine, terizidone and PAS. Okay. Group 5 agents are drugs which have in vitro effect on TB bacilli, but in vivo effect we are not we do not know, or their long-term safety we do not know. Of which you have a new molecule. This is the first time in the last 40 years that a drug for TB has been discovered, bedaquiline. And this is the first time this drug has come, still not available in India. At the moment used only in adults, safety has not been established in children, dosing has not been established in children. So first drug that has come, it's a bactericidal drug, but it's still labeled as group 5 drugs, not to be used routinely for MDR, it is supposed to be used in salvage regimen. You have linezolid that has come, very effective drug, very useful drug. This drug would probably be going higher up on the list, it should be coming part of group 1 or group 2, it's that effective a drug. Clofazimine, amoxiclav, imipenem, celastin, meropenem, high dose INH which is 20 milligram per kg per day, and clarithromycin which is very, the role is not really defined. So if you are going to use any group 5 agents, last option should be clarithromycin until and unless you are suspecting the patient to have a NTM, non-tuberculous mycobacteria, in which case clarithromycin becomes much higher. Out of your group 5 agents, the drugs that definitely work, bedaquiline, linezolid, clofazimine. Probably imipenem, meropenem, high dose INH. The other drugs have query role which is not yet established. What should be the regimen? Intensive phase should contain at least 4 second-line drugs, which includes an injectable as well as pyrazinamide. You should not consider pyrazinamide as working if your DST is showing negative. It can be a part of the regimen, but don't consider it as part of a drug that is working, susceptible drug. And they should either contain ethionamide with cycloserine or PAS with cycloserine. Don't combine ethionamide and PAS together because chances of hypothyroidism is much higher. So usually you have pyrazinamide, you have a fluoroquinolone, you have an injectable. And among your group 4 agents, ethionamide with cycloserine or PAS with cycloserine. Now I have already shown you data from Mumbai where we have ethionamide high resistance. So probably I wouldn't even use ethionamide as first line. Until unless I am dealing with CNS MDR TB, in which cases I want drugs that penetrate the CNS to be there, for which I would utilize probably ethionamide, pyrazinamide, quinolones. So those cycloserine. So those drugs that penetrate the CNS more would be there as a part of my regimen. So for each patient, the regimen is pretty individualized. It's not a standard regimen that I could follow and say, okay, every patient takes this particular treatment. Sometimes even in MDR TB, I would have used linezolid and not as a group 5 agent, which we actually reserve for XDR patients. I would have used it. If I found that the other drugs like ethionamide, PAS, both resistant, then I would have used it. Cycloserine, we don't do DST, so we don't really know how much is the sensitivity pattern. Treatment duration, intensive phase where you are using an injectable, 8 months. Total duration of treatment, 20 months. Now there's a lot of literature that is coming out. In fact, the latest TB conference in Barcelona, there were 2 papers which have recommended short course chemotherapy for MDR TB in children, which has lasted from 9 months to 1 year. So till we have more data on that about short course chemotherapy, we still stick to 20 months. But there are, if you have lymph node TB, pleural effusion, I mean not very extensive TB, you could get away with just a shorter duration of TB treatment. XDR TB treatment, use any group 1 agent which is working. INH rifampicin is not working, so ethambutol or pyrazinamide. If amikacin is resistant, use capreomycin. If all 3 injectables are resistant, then you would have to use an injectable which you never used before, or probably not use an injectable. Use an quinolone, highest generation, but if you have moxifloxacin resistance, you can't use any quinolone. Then use group 4 agents which you have not used earlier. Use all of them. So you may use PAS, ethionamide and cycloserine, all 3 together, and 2 or more from group 5. So you may also have 6-7 drugs that you are using currently for XDR TB. The new drug that has come, bedaquiline, it's bactericidal. It has an effect on a different mechanism. It works on the ATP synthesis in the mycobacteria. It's got a very long half-life, 5.5 months half-life. It is metabolized by the cytochrome P450 enzyme, especially the 3A4. So you have a lot of drug interactions with this molecule, and it's eliminated in the stools. Dose for adults, we know 400 milligram once a day for 2 weeks, followed by 200 milligram 3 times a day, 3 times a week for 22 weeks. Because of the long half-life, you could get away with alternate day regimen. In children, the dose is not known. The most common adverse effects are all GI related, but worrisome is QT prolongation. So you should not use it with drugs that cause prolongation of QT interval, especially the fluoroquinolones. You should not use it with rifampicin because rifampicin induces this enzyme and metabolizes this drug faster. So the TDMs would actually be 50% of what the dose you've given. Even with ART, efavirenz also induces this enzyme. So you may have to increase the dose of bedaquiline when you're using efavirenz or rifampicin together. So a lot of drug interactions are there with this drug. Safety, dosing in children not yet established. Whenever you are following up these patients with MDR TB, you have certain definitions on outcome. When will you say that the patient is cured? When there are at least 3 cultures negative, 30 days apart, after the intensive phase. So in the continuation phase, you have 3 cultures that are negative. Very difficult to do in children. You hardly ever can manage to send a sample for testing in the first place. So to document 3 cultures negative at the time of completion of therapy is not possible. So then we label the patient as treatment completed, where we have given at least 20 months of therapy as per the policy, and we've not done any cultures, but clinically, radiologically, the child has improved. So when you find a clinical improvement, radiological improvement, and you complete the total 20 months of duration, you say treatment completed. So most of the patients are going to be treatment completed in the pediatric age group rather than cured. Treatment fail. When do you call it a treatment fail? When after the intensive phase also cultures are positive. So even after 8 months, cultures positive. Cultures became negative, but then again became positive in the continuation phase. Or on a repeat culture, you found additional resistance to fluoroquinolones or the injectables coming up. So you had a conversion from MDR to an XDR. Or the patient developed an adverse drug reaction to the regimen and you had to stop the regimen. Probably the treatment failed at that time. And then they used to have a term called as defaulter in the earlier guidelines, which has now been termed as loss to follow-up. So patients who have been lost to follow-up for at least 2 months, you label them as lost to follow-up and not defaulter, because you can't trace this patient. How do you monitor bacteriological conversion? It has to be on the basis of culture. Molecular tests currently are not recommended for treatment monitoring. Though it may come up in the future, but currently not recommended. So don't use Xpert or LTBI to monitor response to treatment. It's only on the basis of culture. The other things that are issues with MDR treatment is you're giving so many drugs that it's a pill burden. You are almost giving 13 to 14 pills a day. So patients become very non-compliant with it. They will not adhere to it. Getting them to be compliant to the regimen becomes major issue. Cost is an issue until unless you're in the government program, where probably you will be on a regimen where only 2 drugs are working, or the patient is buying the drugs, then the cost goes up. For a child of 10 to 15 kilos, the cost comes to 5 to 6,000 a month. Older child weighing more, cost is almost 10 to 15,000 a month. So that's how expensive the therapy is. Side effects, I told you, a lot of side effects. Aminoglycosides, nephrotoxicity, ototoxicity. You have PAS that has GI, hypothyroidism, ethionamide, GI, hypothyroidism, pyrazinamide, uric acid problems, hepatitis. So a lot of issues of side effects that are there. And at the end, you don't know what the final outcome is. Whether this patient is going to live, this patient is going to die, you're going to have surgery in this patient, do you need to get a lobectomy done, whether this patient is going to go into an XDR TB, whether this patient is going to be infectious to the community and keep on spreading the bacilli. So the final outcome is guarded. Our data from our center, we've had good results in MDR TB. XDR TB, 50% did not respond at all. There were a few patients where we had to make them undergo lobectomy to get the disease under control. So till MDR TB, good outcome. Beyond that, pre-XDR, XDR, prognosis becomes guarded. Drug-resistant TB is on the rise. Currently, only one drug has come up, new molecule, bedaquiline, but safety in children not yet established. Instead of MDR, it's pre-XDR and XDR that is a coming up issue. Side effects are a real major issue to deal with, and outcome remains guarded. Thank you very much.